Esophagogastroduodenoscopy, also called EGD, is used to visualize the upper GI tract, including the lumen of the esophagus, stomach, and duodenum. Indications for this test, it's used to evaluate dysphagia, unexplained weight loss, upper abdominal pain, bloody emesis, suspected varices or varicose veins in the esophagus, ulcer symptoms. It's also used to evaluate tumors. So what it is a long, flexible fiber optic lighted scope. It's got 3 channels, and it's inserted through the patient's mouth. The first channel is for viewing, so it's got a camera attached. The second channel is for instilling air or for suctioning secretions. And the third channel is for inserting instruments. You can obtain biopsies of tissue, widen narrowed esophagus, remove tumors, stop active bleeding, and place feeding tubes during an EGD. It's contraindicated with possible perforation or with severe upper GI bleeding. So pre-op, you need consent. Instruct the patient to stop aspirin and anticoagulants as directed by the doctor. NPO at midnight before the test. Explain that they will be consciously sedated in a twilight state, which means they'll still be awake and able to breathe on their own, but they will not remember anything. The nurse will administer Versed and fentanyl usually to begin sedation. Gagging may occur during, but again, the patient will not remember. IV fluids are started to prevent dehydration because again, they've been NPO since the night before the test. Post-op, you want to get vital signs every 15 minutes for an hour. They need to have their gag reflex intact before you give them anything by mouth. So they're going to have a numbed throat because of the spray that they put there to hopefully stop the gag reflex during the procedure. So you need to make sure that they have a gag reflex before giving them anything by mouth. They will need someone to drive them home. No driving for 24 hours due to that sedation. Throat will be hoarse, and belching and bloating will occur because their stomach is inflated to better view it. So complications of an EGD is perforation of the GI tract, bleeding, aspiration, over-sedation, and hypotension. So a colonoscopy is used to diagnose suspected pathological conditions of the anus, rectum, colon, and part of the distal small bowel. Indications for a colonoscopy would include changes in bowel habits, blood in the stool, abdominal pain, or it's used as a surveillance tool for cancer and inflammatory bowel disease. It's similar to the equipment as an EGD, but it's inserted through the anus. Can do the same things as the EGD scope, such as collect biopsies, remove tumors, stop bleeding. It's recommended as a surveillance tool for those with a strong family history of colorectal cancer under the age of 50, as well as those without a family history that are between the ages of 50 and 75. It's usually done every 5 years. Contraindications for colonoscopy would include profuse GI bleed, suspected perforation, or a recent bowel surgery. Pre-op, so you need consent for this test as well. Again, instruct them to stop aspirin and anticoagulants as directed by the doctor. Usually about 7 days prior, they need to stop those anticoagulants. They're going to have a colon prep or a bowel prep, which includes clear liquids the day before. Nothing with a red or orange dye, because it can resemble blood during the procedure. So instruct them they can have Jello, clear liquids, but make sure that there is no red or orange dye in those clear liquids. Well, they will have specific instructions for their bowel prep cleansing. Some doctors prefer enemas, others prefer strong laxatives. Regardless of their prep, their output needs to be clear by the morning of the procedure. They will have conscious sedation like the EGD, and they may talk during the procedure, but again, they won't remember. And they also have IV fluids to prevent that dehydration because they're going to be NPO after midnight besides their prep. The only thing they're going to have by mouth is that prep. Post-op, they will also need somebody to drive them home, just like for EGD, no driving for 24 hours due to the sedation. They will have a lot of gas. Observe for potential perforation or shock. So you're going to check their vital signs every 15 minutes for 1 hour. They can eat when they're fully alert because nothing went in their mouth, so their throat wasn't numbed. They should have an intact gag reflex. And you're going to instruct them to increase their fluid intake. Complications of a colonoscopy include bowel perforation, persistent bleeding from a biopsy site, and oversedation. Barium contrast is a test that includes ingestion of a radiopaque dye and a subsequent X-ray to view where that dye is in the GI tract. Indications for this test is to visualize the position, shape, and activity of either the esophagus, stomach, small intestines, or large intestines, or all of them. It's used to evaluate inflammatory bowel disease, large bowel obstructions, suspected tumors, dysphagia, GERD, delayed gastric emptying. It's contraindicated if perforation is present or a small bowel obstruction is suspected. It can be administered by a barium swallow, so the patient actually swallows the dye, or by an enema. If it's by an enema, their only visualization will usually be the large intestines and a portion of the small intestines. If they swallow it, they can see the entire tract. It's administered during a fluoroscopy X-ray. So pre-op, they're NPO 8 hours before, ideally. They might need antiemetics because the contrast isn't very appetizing. It's not tolerated well with most people. If they are having difficulty swallowing, they might place an NG or nasogastric tube to administer it. If they're having it by enema, they might need a bowel prep, like we talked about with the colonoscopy, so laxatives or cleansing enemas to clear that colon before the introduction of the barium contrast. So during the test, the patient is asked to reposition frequently to coat the entire tract. After the time it takes for the dye to set in, they will have a video or fluoroscopy X-ray that will visualize where the dye is in the tract. Post-op, the patient needs to evacuate all of the barium. So laxatives are usually recommended and ordered after a barium test. So they need to evacuate all of that barium. The reasoning for this is that it tends to give them bowel obstructions because it hardens the stool and it's very hard for them to have a bowel movement after, so that's why they push laxatives after the test. Their stool will be white initially from the dye, but it will return to a normal color after all of the barium is expelled. So they need to also increase their fluids to help with having a bowel movement. The complications is, like I talked about before, that fecal impaction due to the barium in the stool. Endoscopic retrograde cholangiopancreatography, or ERCP for short, is a test used to evaluate reasons for jaundice and for unexplained abdominal pain or chronic pancreatitis. It's similar to an EGD. It's the same type of procedure, similar scope, but it visualizes the bile and pancreatic ducts. Stones, benign strictures, cysts, stenosis, anatomic variations, and malignant tumors can be identified in these ducts. During the test, they can widen these ducts. They can remove small stones, insert stents to keep the ducts open, and they can also take biopsies. It's contraindicated in patients with perforations or severe acute pancreatitis. So it's only used in a pancreatitis patient if it's a chronic pancreatitis. Pre-op, they're going to need consent. Teach that they need to lie still during the procedure. They'll be consciously sedated like an EGD. Check for allergies to dye, because they might use dye during this procedure, unlike an EGD where they don't use dye normally. Post-op instructions is the same as EGD, but more focus on observing for ERCP-induced pancreatitis. So the problem with these tests is that it's used to evaluate chronic pancreatitis, but it can also induce pancreatitis from the irritation of the ducts during the procedure, can inflame the pancreas and cause an acute pancreatitis. So complications is a new pancreatitis or worsened pancreatitis from the pressure of that dye injection and the scope in the ducts. They can perforate, or they can over-sedate. Going back, so same, like I said, the same post-op instructions as the EGD. Don't let them eat or drink anything until their gag reflex returns, and don't let them drive home because of that conscious sedation. And then teach them the signs and symptoms of acute pancreatitis, because again, this ERCP can cause acute pancreatitis. Feel free to do these knowledge check questions. I'm not going to do them over recording. I'll go over them in class on Thursday, but feel free to try to answer them and be prepared to discuss them during class. So now we're going to move on to disorders of the esophagus and stomach. We're going to start with gastroesophageal reflux disease, or GERD for short. GERD is the most common upper GI disorder in the United States. It occurs most often in middle-aged and older adults, but it can affect people of any age. GERD occurs as a result of reflux, or backward flow of GI contents into the esophagus. The incidence of GERD is increasing throughout the world, not just in the United States. GERD is often due to an incompetent lower esophageal sphincter, diaphragmatic hernia, or delayed gastric emptying. GERD is persistent reflux, so it's not just people that complain of reflux or heartburn here and there. It's persistent and almost constant reflux. So reflux produces symptoms by exposing the esophageal mucosa to the irritating effects of gastric or duodenal contents, resulting in inflammation. A person with acute symptoms of inflammation is often described as having reflux esophagitis, which might be mild or severe. So keep in mind that the pH of the stomach is 2 and the pH of the esophagus is 6 to 7. So that acidity of the stomach really harms the esophagus. So who's at risk? Anyone with an increased intra-abdominal pressure, so pregnant women, obese individuals, weightlifters, or people that have a physically active or overly exert themselves physically, like in their job or just day-to-day life. Alcoholics and elderly are also at risk because of the damage to of the alcohol to the lower esophageal sphincter, and then elderly just tend to have that incompetent esophageal sphincter. Children can also have GERD, and that's just due to the immature sphincter, which may manifest as vomiting and weight loss, because the infants usually can't tell you, I'm having reflux, so it manifests as vomiting and weight loss, or a lack of weight gain. Manifestations of GERD is burning, bloating, regurgitation, dysphagia, heartburn, dyspepsia, which is just indigestion, or which is basically nausea, fullness, burping. Other manifestations include sour, bitter taste, nocturnal cough, so a cough at night, wheezing, and hoarseness upon waking. So what happens is they lay down at night and the reflux gets worse because of gravity, and they wake up with that hoarse voice and wheezing from the burning of the stomach contents. Pain that occurs after meals, so 20 minutes to 2 hours after meals. Sometimes it's relieved by food or antacids or standing or walking. This pain can mimic heart symptoms. So patients that have both problems, if they have GERD and angina, or if they've had a previous MI, this pain is obviously not relieved with nitroglycerin. Pain increases when lying down, bending, any exertion, and after heavy meals. Complications is pre-malignant esophageal cells. This is called Barrett's esophagus, and it's from that repeated acid exposure leading to scar tissue and abnormal cells. Other complications include esophageal strictures, erosions, asthma, because those contents can come up and go into the lungs, laryngitis, and pneumonia. GERD is diagnosed by barium swallow, EGD, or by pH testing. So they'll go down into the esophagus and they'll do a pH test and see if it's acidic or if it's at that 6 to 7 range that the esophagus should be at. Treatment meds are the mainstay of treatment, which we'll talk about on the next slide. They need to rule out a cardiac origin, especially if this is a new thing for them. So they'll usually have a complete cardiac workup initially, so they'll have those EKGs, enzymes, they might have a stress test. And then in severe cases, they might have a fundoplication, which we'll talk about later. It's a surgery to help reduce that reflux. But the rate of recurrence is high even after that surgery. So priority nursing care, teaching is priority. Teach them to lose weight, avoid overeating and gassy foods, teach those small frequent meals with fluids between. Important to tell them to sit upright 1 to 2 hours after eating. That helps to reduce that gravity pulling those stomach contents up. So sit up 1 to 2 hours after eating. No caffeine, no smoking, no alcohol. For their diet should be low fat and high protein. Avoid constipation. Teach not to snack at night. So especially 1 to 2 hours before they go to bed, they shouldn't be eating. Their head of bed should be 6 to 12 inches up at night. So raise the head of the bed 6 to 12 inches at night. Avoid intra-abdominal pressure, so straining, bending over. Post-op care, if they've had a fundoplication, is a nursing priority, which again we'll talk about later. Teach parents of infants with GERD to increase the calories in the formula or milk by adding cereal. GERD meds. Keep in mind that these meds are used for a lot of the GI disorders that we're going to talk about in this unit, not only GERD alone. So you might hear me repeat some of these meds later on. But antacids, examples of antacids is Tums, Mylanta. These are over the counter. You're going to give these 1 hour after meals and at bedtime. Don't give other drugs within 1 to 2 hours of antacids. Some have a high salt content, so caution patients that have congestive heart failure and hypertension about the salt content. Gaviscon is alginic acid that produces a viscous foam and coats the esophagus. It floats on food, so you need to instruct them to take with food or after meals. Proton pump inhibitors are very common. You'll see a lot of patients in clinical with a proton pump inhibitor. These suppress secretions, inhibit stomach acid production. Long-term use can predispose the patient to fractures due to the interference of calcium absorption. These are taken daily or twice a day. Some are over the counter and others are prescription. These meds end in Prazole, P-R-A-Z-O-L-E. Teach the patient not to stop these abruptly because there's a risk of a rebound effect. Examples of the proton pump inhibitors are omeprazole, which is Prilosec, esomeprazole, which is Nexium, pantoprazole, which is Protonix. Esomeprazole and pantoprazole can be given IV or PO. H2 histamine blockers, these decrease secretions. They end in tidine, T-I-D-I-N-E. Can be PO or IV. Do not give these within 2 hours of antacids because they will interfere with each other. Examples of these is ranitidine, which is Zantac, and famotidine, which is Pepcid. Promotility agents, this is for moderate to severe cases of GERD. The examples are metoclopramide, which is Reglan. Give this before meals. It promotes peristalsis and gastric empty. They can have a psychotropic effects, the EPS, which you guys probably learned about in mental health, sedation, headache, and dizziness. Nursing care, if client is not having relief of their symptoms, ask the patient how they're taking their medication. They might not be taking their medication at the correct times. So ask them, when are you taking your proton pump inhibitor? Or when are you taking your antacid? When are you taking Gaviscon? They might tell you that they're taking it before meals when they should really be taking it after, or vice versa. So make sure you're talking to your patients and getting their routine down to figure out why they're not getting that relief with the medication. And then observe for side effects of the drugs that are given. Pyloric stenosis is a disorder of early infancy. Begins after 4 to 6 weeks old. Males are affected more often than females. If it's happening in an adult, which is not terribly common, it can be called gastric outlet obstruction. So what happens is there is an obstruction at the sphincter by hypertrophy of the circular muscle of the pylorus, which results in severe narrowing, inflammation, and edema. The cause is unknown, possibly genetic. Signs and symptoms include regurgitation of food that leads to projectile vomiting after feeding. So it's not just simply vomiting, it's a projectile vomiting after feeding, which is the hallmark of this disorder in infants. They'll have weight loss or no weight gain, lethargy. They might have a sausage-shaped mass in the right upper quadrant, dehydration, visible peristalsis, small and frequent stools. The infant might be irritable or hungry all the time. Diagnosis is ultrasound, barium swallow. If it's happening in an adult, they might have an EGD. Conservative therapy is placing the infant upright during and after feeding. They may need hospitalization to rehydrate, replenish electrolytes, correct alkalosis. Surgical therapy is a pyloromyotomy or stent. A pyloromyotomy is the surgical splitting of the pyloric sphincter. Post-op care requires glucose water every 4 to 6 hours if it's an infant. If that glucose water is tolerated for 24 hours, then they can advance the infant to formula or breast milk. Vomiting is not uncommon the first 48 hours post-op, but it's not that projectile vomiting like they had prior to surgery. The child may require an NG tube and repeated barium testing if they continue to have projectile vomiting or if they just continue to vomit in general. Priority nursing interventions Other nursing interventions besides the post-op care we talked about is strict I&O, parental support. You're going to do your physical assessments, assess for pain, and their hydration status, elevate the head of the bed. If they have an incision, make sure you're assessing that for signs and symptoms of infection. Gastritis is an inflammation of the gastric mucosa. It can be erosive or non-erosive, and it can be acute or chronic. So in gastritis, the patient is lacking prostaglandins that work to prevent the stomach from digesting itself, leading to injury and histamine release, which results in inflammation of the gastric mucosa, and that further interferes with the acid and pepsin secretion. Contributors to gastritis is alcoholism, smoking, stress, food allergies, pathogens. So pathogens can be viral or bacterial. The most common bacteria is H. pylori. Other causes is chemo, radiation therapy, major surgery, burns, steroids, and NSAID use. So this is why it's very important to ask your patient if they're taking NSAIDs and how often, because how NSAIDs work is they interfere with the prostaglandins. So that's the major cause of gastritis, is lacking those prostaglandins. So asking them about NSAIDs or aspirin and seeing how often they're taking them, especially if they have a stomach issue. Signs and symptoms can include fever, left upper quadrant pain, nausea and vomiting, headache, loss of appetite. It's usually diagnosed with an EGD with a biopsy for underlying cause. So they'll take a biopsy of the tissue to figure out if it's viral or bacterial, and then asking the patient those questions about their lifestyle, about alcohol, smoking, stress, NSAID use, and things like that. Treatment, if they have chronic gastritis, they may need vitamin B12 to reduce the risk of pernicious anemia, like we talked about in the last unit. In acute gastritis, they may be NPO, or they might have clear liquids, and advancing their diet as tolerated as their pain decreases. Strict I&O, IV hydration. They might have meds such as antacids, antiemetics. The doctor might prescribe any of those GERD meds that we talked about previously, so proton pump inhibitors, H2 blockers, things like that. If the results come back as bacterial, they might be on an antibiotic. Priority nursing care, teaching them no NSAIDs or aspirin, avoid alcohol, stress, smoking. Similar dietary modifications as GERD, so low fat, high protein. Hiatal hernia is also called a diaphragmatic hernia. It's a condition where the stomach protrudes through the opening in the diaphragm into the chest. Most patients are asymptomatic. Signs and symptoms are similar to GERD. And the risk of GERD is increased due to the increase in intra-abdominal pressure from that hiatal hernia. In severe cases, the entire stomach can herniate into the chest, which can result in stomach strangulation, obstruction, and difficulty breathing. It's diagnosed with an EGD, barium swallow, and it's also visualized on a CAT scan. Treatment is niacin fundoplication if it's large. If it's small, it's treated conservatively, similar to how GERD is treated. But then the niacin fundoplication is a surgery that wraps the fundus of the stomach around the esophagus. Post-op care involves NG tube maintenance to aspirate the acid from the stomach during healing. Good oral care because they're going to be NPO. They might have possible total parenteral nutrition for the time that they're nothing by mouth. Diet after the NG is removed is high calorie and protein, and you're to keep the patient in semi or high Fowler's position 2 hours after eating. Priority nursing care, if it's conservative treatment and not surgical, is the same teaching and nursing implications as we talked about in GERD. Peptic ulcer disease. Peptic ulcer is a mucosal lesion of the stomach or duodenum. About 80% of the ulcers are in the duodenum. Peptic ulcer disease, or PUD, results when mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsid. So, like I talked about in gastritis, this is like a subsequent disorder from something like gastritis, where the mucosal defenses are down and results in erosion. So, like I said, erosive gastritis leads to peptic ulcer disease. 3 types of ulcers may occur, and they include gastric ulcers, duodenal ulcers, and stress ulcers, which are less common. Most gastric and duodenal ulcers are caused by H. pylori infection. I talked about that in gastritis. It's a bacteria that is transmitted via the fecal-oral route and thought to be acquired in childhood. It can also be transmitted from contaminated endoscopic equipment, like during EGDs or ERCPs. About half of the world's population is infected with the bacterium. Causes and risk factors for peptic ulcer disease are NSAIDs. I talked about that before. They decrease the prostaglandins, which the prostaglandins produce mucus that protect the stomach lining. So by taking NSAIDs, they're decreasing those prostaglandins. And aspirin goes along with the NSAIDs. Stress, smoking, alcohol. This has some genetic component. It's often seen in family members. Steroids, excess gastric acid secretion, that bacteria H. pylori. Saliva can also transmit the H. pylori, but not everyone who has H. pylori gets an ulcer. Signs and symptoms is dull left upper quadrant or epigastric pain, burning or gnawing pain, especially a half hour to 1 hour after eating, gas, heartburn. Symptoms can be continuous or can come and go intermittently. Diagnosis is an EGD is the most diagnostic because they can visualize the ulcers and they can take biopsies of the ulcer sites to determine if it's from that H. pylori. They might also have a white blood cell count, which is elevated. Their electrolytes might be abnormal. They might have a decrease in hemoglobin and hematocrit if the ulcer is bleeding. So they might also do a stool for occult blood to make sure that that ulcer is not bleeding. Treatment, meds are the same as GERD, plus they might add sulcrafate, which is a mucosal healing agent. It binds to proteins in the ulcer bed and coats that ulcer to protect it so it can heal better. Give sulcrafate on an empty stomach 1 hour before meals, and do not give it with other meds. So sulcrafate binds to the proteins in the ulcer bed and coats and protects it, and give it 1 hour before meals and not with other meds. They might have an antibiotic ordered if they find that H. pylori is present. If they are having a GI bleed from an ulcer, they might need IV fluids, blood transfusions if they're low enough. They're probably going to be NPO until they can get in and do an EGD and try to fix the bleed. Priority nursing care, teaching is priority, especially proper use of medications and complications to look for, such as black stools, because that is a sign of a GI bleed. Teach them signs and symptoms of like anemia, because if they're bleeding, the only sign might be fatigue, shortness of breath, things like that. Same teaching as GERD, 6 small meals per day, fluids in between, Diet and lifestyle modifications: quit smoking, quit drinking alcohol, reduce the stress. Emphasize that they need to avoid NSAIDs and aspirin and any other contributing factors. Assess for complications, signs and symptoms, including severe abdominal pain, abdominal rigidity, GI bleeding, fever, hypotension, shock. If a bleed is present, they're going to be NPO. You're going to prep them for the EGD, monitor their vital signs frequently, strict INO, making sure that you're documenting every bowel movement, including how much and the color. And then they're going to be on IV hydration until they can get in to fix that bleed with the EGD. Diet, you're going to want to have them choose a healthy diet full of fruits, especially with vitamin A and C, vegetables and whole grains. Not eating vitamin-rich foods may make it difficult for their body to heal that ulcer. Decrease or eliminate milk, which increases acid production. A lot of times people think that milk helps them because it temporarily relieves the pain, but in the end it's just making more acid. Complications of ulcers is a GI bleed, which manifests as bloody vomit, or melena, which is black stool. Perforation, which can lead to peritonitis, which we'll talk about next. Shock and sepsis, and finally gastric outlet obstruction. Moving on to the disorders of the intestines and connecting structures. So first we're going to talk about appendicitis. Appendicitis is an acute inflammation of the vermiform appendix that occurs most often among young adults. It is caused by an obstruction of the lumen of the appendix by feces, which causes inflammation and infection, and it can form abscesses, cause necrosis, and it can rupture. It is the most common cause of right lower quadrant pain. It's usually acute, more common in teenagers, young adults, and males. Complications include bowel perforation, peritonitis, abscess, and sepsis. Signs and symptoms: right lower quadrant pain. Light palpation reveals rebound tenderness in the right lower quadrant. So you'll push down and they're not feeling pain, but when you let up is when they're experiencing the most pain. The patient will be guarding, possibly in the fetal position. If they have a rigid board-like abdomen, then most likely peritonitis is present. They'll have an elevated white count, inability to stand straight up. They need to bend over to put pressure on the appendix. They might have a low fever. If the patient suddenly experiences pain relief, the appendix may have ruptured. Treatment is the surgical removal of the appendix and antibiotic therapy. So pre-op, you're not going to give them narcotics and nothing rectally, including laxatives, cathartics, enemas, and no heat applications before. You can apply ice, but no heat, nothing rectally, and no narcotics. So the reasoning for no narcotics is it masks the pain, and you need to know that if the patient experiences that sudden pain relief, then the appendix has ruptured and it's more of an emergency surgery. So no narcotics prior to, nothing rectally, and no heat. Post-op care is, I should go back to pre-op care. So they're going to need a consent. They're going to be NPO because it's a surgical procedure. They're going to going to the OR. So NPO, consent, and things like that. Post-op care is advancing their diet as tolerated. Unless an NG tube is present, then they'll be NPO. Assess the wound, the dressing, the incision, bowel sounds, and pain. They might have a JP drain, or an NG tube if there were complications, such as if the appendix was necrotic or if it was ruptured, or if they had a bowel perforation or peritonitis. Nursing responsibilities include standard post-op care, assess bowel sounds, ask about passing gas, because you need to know that the bowels are working and then they're not having an obstruction in their bowels from the surgery. Ambulate them as soon as possible, palpate their abdomen, get that baseline feeling on how soft their abdomen is, because they can develop peritonitis even after surgery. So make sure you're getting that baseline palpation right when they come back from surgery, because if it becomes rigid, then you know that there's an issue. At this point, they can have analgesics such as narcotics. Peritonitis is a life-threatening acute inflammation of the visceral and/or parietal peritoneum and endothelial lining of the abdominal cavity. Causes any abdominal organ that contains bile or fecal matter that has ruptured or perforated can cause peritonitis, including a ruptured appendix or diverticulum, a ruptured hernia, ulcer perforation. Trauma can also cause peritonitis, so abdominal trauma, abdominal surgeries, things that just disrupt that abdominal cavity. Signs and symptoms is severe abdominal pain, tender to palpation. The hallmark is a rigid board-like abdomen. So it's like they have hard abs, but they don't have abs. It's just severe inflammation. So rigid board-like abdomen. Nausea, vomiting, chills, fever, weakness. They're going to have a low blood pressure, dehydration, decreased bowel sounds. They might be in the fetal position, and signs and symptoms of shock could be present. Diagnosis, they're going to have a white count done, and it will be high. A KUB, which is called, it's a kidneys, ureter, and bladder x-ray. So this basically just means an abdominal x-ray, but they like to confuse us and call it a KUB. So if you see that KUB, that just simply means an abdominal x-ray. CBC, a chemistry profile, a CAT scan, and an ultrasound might be done. Treatment is exploratory laparotomy surgery to find and fix the cause. If it's not seen on the imaging, they might have the exploratory laparotomy to find the cause, but they're going to have this procedure regardless to fix whatever the problem is. This is an open abdominal surgery because they're exploring the entire abdomen. They're going to need antibiotics. They're probably going to have an NG tube to aspirate the acid in the stomach, and to, especially if it was a perforated stomach, like a perforated ulcer, they're going to have an NG tube. They're going to need IV fluids, and they're going to be treated if they're in shock, so they're going to have shock treatment. Priority nursing care is keeping them semi-Fowlers, assess their I's and O's, their fluids and electrolytes, frequent vital signs. After the surgery, you're going to do standard post-op GI care, coughing and deep breathing with splinting. With any abdominal surgery, you're going to have the patient splint their abdomen while they cough and deep breathe. It helps decrease pain, and it decreases the chance that their incisions are going to dehiss or open. Ambulating them as soon as possible to prevent an intestinal obstruction from the surgery. Monitor the dressings and incisions and any drains that they're going to have. If it was a perforation problem, they're probably going to have a JP drain after surgery. Hernias are protrusions or outpouching of organs or structures from its original cavity through a congenital or acquired defect or weakness in the muscles of the abdominal wall. The incidence is 3 times more likely in men, but these may occur at any age. It's often caused by increased intra-abdominal pressure from coughing, straining, lifting, or a nearby tumor. It can also be due to obesity or pregnancy. There's different types of hernias. We had already talked about a hiatal hernia earlier. The hiatal hernia is a protrusion of the stomach up into the chest cavity. The hernias that I'm talking about now are protrusions of organs through the muscles of the abdominal wall. So these hernias you can actually see. A hiatal hernia you can't actually visualize with your own eyes. So the types, first one is inguinal. This is in the groin area, and it can descend into the scrotum if it's in a male, and they're more common in males. Umbilical is around the umbilicus or the belly button, and this can be congenital from birth or acquired. And then another one is incisional. This is through an incision. It's also called a ventral hernia. It can be at a fresh incision or at a site of a previous incision that's already been healed. Classifications, the first one is reducible. So this means that the hernia is able to return to its original position with manual, gentle manipulation. This is painful, reducing it at the bedside, so they're most likely going to need pain medication prior to. The next one, which I'm combining irreducible and incarcerated because they're the same thing. These are not able to return with gentle manipulation, and there's a chance that it can obstruct intestinal flow. And then the final one is strangulated. So this is an emergency. Blood supply and intestinal flow has been cut off or occluded, and the bowel will become necrotic. The bowel can rupture, and the patient may become septic without intervention. They're going to have extreme pain, distension, and vomiting. Signs and symptoms in general is a small mass that's palpated or visually observed. Pain and burning might be present, and again, it's much worse if it's actually strangulated. Some patients are asymptomatic aside from that mass that they see. So some patients don't feel anything. Treatment of choice for hernias is a surgical reduction to prevent the chance of strangulation. So a hernioplasty is a synthetic mesh that's sewn in that adds strength to that muscle to prevent the organs from protruding. This is more common nowadays, but there's also a lot of complications to this. The mesh becomes part of the person's body, and it can become infected, and there's been a lot of lawsuits. I'm sure if you watch those commercials, if you've had a hernia mesh and had complications, we can help you sue the hospital. So there's been a lot of complications to the hernioplasties. The hernia raphe is a less common, but it's less complications to the surgery. The area is repaired, and layers of muscle and fascia are sewn together to prevent reoccurrence. But reoccurrence tends to be higher in this surgery rather than hernioplasties. But again, the hernioplasties have a lot of different complications that go along with them. Hernias can be treated conservatively with monitoring if they're not causing problems. They might just need yearly follow-ups, but they usually push people to try to surgically reduce it. Priority nursing care for conservative treatment is monitoring the size of the hernia, bowel sounds, pain. They might have a truss belt, which is a padded belt that helps keep the contents in after it's been manually reduced. So without surgery, they can, if it's reducible, they can manually reduce it, and the patient may wear a belt to just help keep those contents in after reduction. Teach the patient to avoid things that cause increased intra-abdominal pressure. Nursing implications if they've had surgery is standard post-op care, monitoring their incision, vital signs, I&O. If it's a inguinal repair, you're going to elevate the scrotum and ice it. Teach to deep breathe and use an incentive spirometer, but no coughing because that increases intra-abdominal pressure. So teach to do the deep breathing with the incentive spirometer, but no coughing. Monitor for urinary retention, especially if it was an inguinal hernia repair. Infection, scrotal edema. Teach to splint when moving. So splinting that area to prevent the incision from dehiscing or preventing another hernia from happening. They're going to need pain medication. Prevent straining with bowel movements, so giving them stool softeners because again that straining causes increased intra-abdominal pressure. And teach to avoid heavy lifting for 6 to 8 weeks post-op. Here are some images of hernias. The top left is an inguinal hernia, so it's in the groin area. The top middle and top right are umbilical hernias, so around the belly button. And the bottom 3 photos are incisional or ventral hernias. So it looks like most of these are incisions that have healed previously. And the bottom left photo is a very large hernia.